vaccines and improve immunization policy in our state. So with that, I'll turn it over to Sarah J. and just want to send a lot of appreciation to Within Reach for partnering with us to make this webinar possible. Thank you.
Thank you, Sarah. It's my pleasure to introduce our speaker, Dr. Evans. She's a physician in the Division of Adolescent Medicine at Seattle Children's Hospital, as well as being on faculty at the University of Washington. She earned her MD from the Oregon Health and Sciences University, her MPH from UW, and completed her adolescent medicine fellowship through the UW Center for AIDS and STD Research with a focus on sexually transmitted infection prevention. Dr. Evans is dedicated to reaching teens where they are, and she goes the extra mile, both literally and virtually, to do so. She cares for patients in Seattle, Federal Way, and Olympia. She blogs at Teenology 101 on the children's website and works through telemedicine as well. At Within Reach, we've had the distinct pleasure of working with Dr. Evans to promote HPV vaccination, both through a distance learning course we collaborated on and at multiple in-person training opportunities. And while I myself am not currently the parent of an adolescent, I have to tell you the thought has crossed my mind that if I were, the opportunity to take them to see Dr. Evans would be a silver lining. That's just how delightful she is. So thank you so much, Dr. Evans, for sharing your expertise with us this morning. I'll turn it over to you.
Thank you so much, Sarah J., and thank you, Sarah Rockton. And everybody, I'm excited to be here this morning talking with you for my time spent providing the presentation. Otherwise, I do not have any conflicts of interest to report. And for our outline, stagnant HPV vaccination rates are leaving another cohort of boys and girls vulnerable to devastating HPV cancers, and vaccination could prevent most of these cancers. So in this presentation, we'll have up-to-date information on the HPV infection, HPV-related disease, and HPV cancers, HPV vaccine information and recommendations, as well as HPV vaccine safety and impact will be reviewed. The presentation also provides evidence-based suggestions for successful HPV vaccine communication with patients and their parents, as well as the current HPV vaccine communication resources available from the CDC. So we're going to start by talking about infection and related disease and cancers. Then we'll talk about HPV vaccine information and recommendations, HPV vaccine safety and impact, and towards the end we'll have communicating with patients and families and responding to FAQs about the HPV vaccine. So our learning objectives for today, we're going to define the importance of HPV vaccination for cancer prevention, explain the rationale for vaccinating at ages 11 or 12, list indications for HPV vaccine for boys and for girls, and share strategies for providing useful and compelling information about HPV vaccine to parents to aid in their decision to vaccinate. The first section is on HPV infection and disease prevalence. So HPV types differ in their tendency to infect cutaneous and mucosal or genital epithelium. There are approximately 40 types frequently found in the genital tract, and these are grouped as high-risk or oncogenic types, including HPV-16 and HPV-18. Persistent infection with these types can result in cancers, including cervical or anal genital and oropharyngeal cancer, and low-grade cervical disease. Low-risk or non-oncogenic types, such as types HPV-6 and HPV-11, can cause anogenital warts, as well as laryngeal papillomas and low-grade cervical disease. The cutaneous HPV types cause the common hand and foot warts. So HPV is the most common sexually transmitted infection. And the hard part about this virus is that most people never know that they have been infected, unless, if you're a female, you have an abnormal pap with a positive HPV test. And most HPV infections clear, but persistent infection is a precursor for morbidity. Most HPV infections happen during the teen and college age years. So we'll talk even more about why it's important to vaccinate early. Each year in the United States, it's estimated that 26,000 new cancers are attributable to HPV, about 17,000 in women and 9,000 in men. These cancers in both men and women could be prevented through timely HPV immunization. HPV immunization for boys does not just protect their partners, it protects them from cancer too. So I won't go through all of the numbers here, but you can see the number of cancers and genital warts attributed to HPV infections in the U.S. as of 2013. And in this slide, we see how many cancers are linked with HPV each year. And you can see for males, the purple are those that are attributed to HPV. Oropharyngeal cancer is the most common. And then for females, cervical cancer is the most common cancer attributable to HPV. But there are a large variety of other cancers that can be prevented with the HPV vaccine. Cervical cancer was once the leading cause of cancer death for women in the United States. And now it's the most preventable of all female cancers. The Pap test has helped decrease the number of women in the U.S. with cervical cancer by about 75% in the past 50 years. However, even with excellent cervical cancer screening programs in the U.S., there's still over 11,000 cases of cervical cancer each year in our country. Many people think of gynecological cancers as just affecting older women, but 1 in 3 cases of cervical cancer affects women who are of reproductive age. And you can see that 13%, or nearly 1 in 8, affect women between ages 20 to 34. So some of those are the patients that I could see in clinic. So here we see that without vaccination, the annual burden of genital HPV-related disease in the U.S. females is fairly high. The estimated annual incidence of low-grade and high-grade dysplasia in the United States is 1.4 million and 330,000 cases respectively. There are an estimated 1 million new cases of genital warts occurring every year in the United States, and more than 100 HPV types have been detected, with more than 80 types sequenced and classified. Approximately 30 to 40 of these types of HPV infect the genital tract. Of these types, types 16 and 18 cause about 70% of cervical cancer and at least 50% of all high-grade cervical dysplasia. And along with HPV types 6 and 11, approximately 35% of all low-grade cervical dysplasias. A study has shown that HPV 6 and 11 also cause 90% of anogenital warts. And I know as a pediatrician, I didn't necessarily think of anogenital warts as a problem until I started my adolescent fellowship and rotated through some of our clinics that serve populations that we tend to not get in clinic, like our juvenile detention population and our homeless youth, where the burden of genital warts was significant. And it really changed my outlook on this vaccine and how important it can be for people and their quality of life. All types of HPV cancers are on the rise, some disproportionately affecting different racial and ethnic minorities. And unfortunately, there is no routine screening recommended for these other HPV-associated cancers. So vaccination is the best and only prevention strategy. And you can see here the breakdown of oral cancer rates that has increased, most predominantly in non-white population members. Cervical cancer affects women of color and their communities more than their white counterparts. Women of color are often diagnosed with cervical cancer at a later stage than white women. Black women are more likely to die from cervical cancer than women of other races or ethnicities, possibly because of decreased access to Pap testing or follow-up treatment. Hispanic women have the highest rates of cervical cancer in the United States. For example, for every 100,000 women living in the U.S., about 11 Hispanic women are diagnosed with cervical cancer, compared to only 7 non-Hispanic women. So now we're going to move on to the next section where we'll focus on the HPV vaccine itself. So HPV vaccines are made from virus-like particles that cannot cause infection with HPV or cause cancer. The HPV vaccine produces a better immune response than HPV infection. Previously, there were two brands of HPV vaccine, Gardasil and Cervarix, on the market. And most recently, the 9-valent vaccine, Gardasil 9 by Merck, was licensed by the FDA in December of 2014. And the Advisory Committee on Immunization Practices voted in favor of including the 9-valent HPV strain vaccine in its recommendations about HPV immunization on February 26, 2015. The new vaccine targets 5 additional strains of HPV, which adds protection against 14% of additional HPV cancers in women and 5% additional HPV cancers in men. No clinical trial data are currently available to demonstrate efficacy for the prevention of oropharyngeal or penile cancers. However, because many of these are attributable to HPV type 16, the HPV vaccine is likely to offer protection against these types of cancers as well. And we'll go into more depth about the dosing series in a little bit. Only HPV 9 is available on the CDC contract as of the end of 2016. The most widely available form of HPV vaccine today is HPV 9, which protects against 9 strains of HPV that can cause cancer and genital warts. So if you encounter quadrivalent Gardasil or bivalent Cervarix, they can still be used in compliance with the Advisory Committee for Immunization Practices recommendations until those vaccines are expired. Routine HPV vaccination is recommended for both males and females between ages 11 and 12 years. Females can receive either the 9-valent vaccine, quadrivalent vaccine, or the bivalent vaccine as supplies last. And males can receive either the 9-valent vaccine or the quadrivalent vaccine as supplies last. Catch-up vaccination is recommended for males and females ages 13 to 26. But the vaccine can be given as early as age 9 for both males and females, and can be given for those adults who want to be protected at ages 22 to 26 years of age. On October 19th of 2016, the Advisory Committee on Immunization Practices voted to recommend the 2-dose schedule for HPV vaccination in some children. The recommendation was immediately approved by the CDC. The ACIP recommends providers start implementing this 2-dose vaccine schedule using the following criteria. Start the first HPV vaccine dose at age 11 to 12 years. The series again can be started as early as age 9. And complete the second and final dose 6 months after the first dose, only if the first HPV dose was given before the teen turned age 15. Some children will still require 3 doses of the HPV vaccine. Adolescents ages 9 to 14 who have already received 2 doses of HPV vaccine 5 months or less after dose 1. Teens and young adults who start the series at ages 15 to 26 still require 3 doses, and teens and young adults ages 9 through 26 with weakened immune systems. And we can refer to the ACIP for specific recommendations about that. For the 3-dose HPV vaccine series, the Advisory Committee on Immunization Practices recommends giving the doses at 0, 1 to 2 months, and then again at 6 months. The minimum interval between doses 1 and 3 is 24 weeks, but they really recommend staying on schedule at the 0, 1 to 2, and then the last dose given at 6 months. This vaccine is administered via intramuscular injection, and just a reminder, it can be given as early as age 9 for both girls and boys. The HPV vaccine is safe, effective, and it provides long-lasting immunity. One of the most common questions that I hear from families and other providers too is how effective is it and is it safe for my child? Well, we know that the HPV vaccine is safe. Safety studies found that the adverse effects are similar to other recommended vaccines for adolescents, which are the meningococcal vaccine and Tdap. And the most common reported adverse effects are really mild, including pain, redness at the site, and a sore arm. The HPV vaccine works. We also see in Australia where 80% of school-age girls are vaccinated, but the number of high-grade cervical lesions have significantly declined. The prevalence of vaccine-preventable HPV types has also declined by more than half in the U.S., where we only have a third of teenage girls who are fully vaccinated. We also know that the HPV vaccine lasts. Studies suggest that the vaccine protection is long-lasting, and we don't have any evidence of waning immunity at 8 to 10 years out. The ACIP and the CDC made the recommendation for the 2-dose vaccine series after a thorough review of data from clinical trials showing that 2 doses of HPV vaccine in younger adolescents ages 9 to 14 years produced an immune response similar or higher than the response in young adults ages 15 to 26 who received all 3 doses. Now we'll move on to the next section, where we will focus on the impact of the HPV vaccine. This vaccine works. The CDC used data collected from the National Health and Nutrition Examination Survey, or NHANES, to determine prevalence of HPV infection before and after HPV vaccine introduction. The HPV prevalence declined by half after vaccine introduction in 14 to 19-year-olds. This is the group we'd expect to see an impact with. The study also showed that the vaccine is very effective, which is what was seen during the pre-licensure clinical trials. And here we'll see the impact of HPV vaccination in Australia. Australia has high HPV vaccine coverage and has seen declines in prevalence of HPV infections, precancerous lesions, and genital warts in young women. HPV vaccine was only recommended for girls in Australia up until 2012. Yet they have seen a decline in genital warts in young men, which shows that there has been a decrease in the transmission of HPV. And now we'll focus on vaccine coverage. The strong coverage rates for Tdap vaccination demonstrate that not only are most preteens and teens getting into the doctor, but they're also getting at least one of the recommended adolescent vaccines. You can see that Tdap and the meningococcal are the two that I mentioned previously that are recommended for adolescents, along with HPV. For adolescent vaccination coverage in our state, Washington State, we have about 47% of adolescent boys and 66% of adolescent girls who've received at least one dose of the HPV vaccine. This is pretty similar to national trends. 28% of teen boys and 45% of teen girls completed the entire HPV vaccine series with all 3 doses. The target for Healthy People 2020 was to receive 80% completion for all 3 doses by 2020. So we still have a long way to go before we meet our national goal. From 2012 to 2013, the percentage of adolescents receiving at least one dose of HPV vaccine increased 3.5 percentage points for girls. A cohort analysis was performed to evaluate receipt of at least one dose of HPV vaccine by age 13 years over time and found an increase since 2007. However, missed vaccination opportunities persist. Had HPV vaccine been administered during healthcare visits when another vaccine was administered, vaccination coverage for at least one dose could have reached 91.3% by age 13 years for adolescent girls born in 2000. High HPV vaccine coverage with existing infrastructure and healthcare utilization is possible in the United States. Taking advantage of every healthcare encounter, including acute care visits, to assess every adolescent's vaccination status can help minimize missed opportunities. And potential strategies include using vaccination prompts available through electronic health records, or checking local and state immunization information systems to assess vaccination needs at every encounter. Series completion also can be promoted through scheduled appointments for second and third doses before patients leave providers' offices after the receipt of their first HPV vaccine dose, and with automated reminder calls. In plain terms, if we eliminated missed opportunities, almost twice as many girls would have received the first HPV dose. And in this section, we're going to talk about parent and provider misperception. This slide shows the responses that parents gave when asked why they would not be getting the HPV vaccine for their daughter in the next year. 3 reasons the parents provided included lack of knowledge, that it was not needed, and that their child was not sexually active. And all demonstrate a lack of understanding on the part of the parent, especially why it is important to vaccinate at ages 11 and 12. Parents need to be told that the HPV vaccine is cancer prevention and that it must be given prior to exposure. Safety concerns can be alleviated by sharing the tremendous amount of data before and after the vaccine was licensed that demonstrate that the HPV vaccine is safe. An important point on this slide is that parents cited that the vaccine was not being recommended by their child's provider as one of the top 5 reasons for not vaccinating. Communication of HPV vaccination during the healthcare encounter is very important to vaccine acceptance. Several qualitative evaluations have been done regarding this issue. Common themes found from these studies show that the vaccine is often presented as an optional vaccine, whereas other vaccines indicated for adolescents were recommended. Also, some providers expressed mixed or negative opinions about the vaccine. When parents expressed reluctance to vaccinate, providers were hesitant to engage in discussion. And finally, some providers shared the parents' view that it was acceptable to delay vaccination until the teen was older. So why is this happening? Providers don't think that parents consider the HPV vaccine to be as important as other vaccines, but parents rate the HPV vaccine importance just as high as all of the other vaccines for children and adolescents. We can see that circled over on the far right. So improving HPV vaccination uptake in the United States can be accomplished through 3 main strategies. Number 1, clinicians can give a strong recommendation for HPV vaccination when girls and boys are 11 or 12 years of age. And clinicians can take advantage of electronic office systems to decrease missed opportunities for HPV vaccination. And finally, communication efforts target both clinicians and parents of adolescents with information about the importance of HPV vaccine for cancer prevention, as well as HPV vaccine efficacy, safety, and impact. In this next section, we'll focus on strategies to improve HPV vaccine recommendations and conversations with patients and their parents. So I'm going to walk you through a 4-step process to aid in your conversations with parents. This communication protocol builds off of a best practice guideline that was developed by Vax Northwest, a partnership that works to decrease vaccine hesitancy in Washington state and to increase childhood immunization rates. The 4 steps that we're going to go through are recommend, ask, acknowledge, and advise. The first step is to recommend it. Research shows that the single most important action you can take with respect to immunizations is to make a strong recommendation in favor of the HPV vaccine. Introduce the topic by clearly stating your recommendation. For immunizations that are due today, we can give examples here. So Quinn should get 3 shots today: HPV vaccine, meningococcal vaccine, and the Tdap vaccine. Another one is Michelle should have 3 shots today that will protect her from cancers caused by HPV and infections caused by meningitis, whooping cough, oh my gosh, sorry, I just lost my train of thought, and diphtheria. The next step is to ask. Ask, what questions do you have, as opposed to, do you have any questions? This shows your willingness to engage in conversation. Also, by asking for questions, you will also hopefully identify the specific nature of the concern. And by restating any concerns, you can show that you've listened attentively. Ask what questions they have about vaccines or the schedule. As an example, what questions do you have for me about vaccines? Then clarify and restate their concerns to make sure you understand. It sounds like you're concerned that the HPV vaccine isn't necessary because Emily is too young and might be sexually active. Am I understanding this? Then acknowledge. Remember, if the parent is accepting, never miss an opportunity to affirm their support, which builds the public will around vaccines. Support the parent's decisions to follow the recommended schedule. Staying up to date with the adolescent vaccine is a great step to take. Keeping your daughter up to date on vaccines is the single most important way our office can work with your family to keep her protected from serious disease. This is also a good time to encourage parents to reinforce the social norm in their communities by sharing with their social networks that they vaccinated their child. If the parent is hesitant about vaccination, you should focus on trust building as opposed to forcing the facts on the parents and data. Emphasize empathetic communication. Validate the fact that the parent has a concern without validating the specific concern. Align yourselves around a common goal, the health of their child, and focus on this priority. Show that you're actually on the same side of the table. Acknowledge the parent's concerns. As an example, there are a lot of different opinions about vaccines and a lot of conflicting information. Make clear your goal is the same as the parent's. I know that you're only asking these questions because you want what's best for your child, and that's what I want too. Name the emotions that you observe, whether the emotion is anger or fear or something else. It sounds like you're feeling anxious about what the side effects of this vaccine might be. Be clear that you're concerned for the health of their teen, not just public health. Public health messaging does not resonate with our parents today. They're concerned about their individual child's well-being. The final step is to advise. Remember, advise is not dictate. Parents want you to be a collaborator with them, not to tell them what to do. Address the parent's specific concerns if there are any. Offer to assist them to get information relevant to their concerns. Allow them time to reflect and consult with their spouse or partner if appropriate. Provide them with an opportunity to revisit their concerns with you, and develop a plan that is acceptable to the parent, noting that you understand that the decision and the burden of responsibility is theirs. Then schedule a follow-up appointment. Of course, this last step is important whether they have accepted or delayed vaccination. If they delay vaccination, remind them that you will bring this up again at every visit because you think it's critical for the health of their child, but you respect their decision. There is a disconnect between provider and parent perception based on either the HPV recommendation or the strength of the recommendation. So make a strong recommendation. A strong provider recommendation is the single best predictor of vaccination. Here's an example of how a strong recommendation could sound. HPV vaccine prevents cancer. I want your child to be protected from cancer. That's why I'm recommending that your son or daughter receive the first dose of the HPV vaccine series today. This next section focuses on succinctly responding to frequently asked questions about the HPV vaccine with patients and their parents. And we've collected frequently asked questions that providers hear from parents and patients and have suggested responses that you can use or tailor to these questions. Why must we give it at age 11 or 12? This is definitely one question that parents might ask. Well, we can respond that the HPV vaccine produces a more robust immune response in preteens rather than in older teens or young adults. And with all vaccines, we vaccinate before exposure occurs. And that's why it's so important to start the series now and to finish it on time. But my child is too young. One provider shared their response with me. If you choose to wait, you are trusting your adolescent to let you know 6 to 12 months before they plan to become sexually active. So allow time to initiate and complete the series. This next question, is this a green light for sexual activity? We have multiple research studies that have shown that getting the HPV vaccine does not make kids more likely to start having sex at a younger age. Would you give it to your child? Well, telling your own personal stories is one of the most powerful ways you can earn parents' trust. Let them know that what you are recommending for their child is no different than what you would do for your own. And I know now that I'm a mom, I have 2 daughters who are too young for the vaccine, but as soon as they're old enough, I'll take them in to start their vaccine series. This is a very common one that people are scared of the side effects. This is not a new vaccine, and for years HPV vaccine has been shown to be very effective and very safe. HPV vaccine has a similar safety profile to the meningococcal and Tdap vaccines. Like other shots, side effects can happen, but most are mild, primarily pain or redness in the arm, and this goes away quickly. The HPV vaccine has not been associated with any long-term side effects. A question that we're asked often is, how long will the protection provided by the HPV vaccine last? And studies suggest the vaccine protection is long-lasting. In 2010, a review of HPV vaccines was conducted regarding the long-term protection against cervical infection with HPV. At the time, the vaccines were shown to provide protection against persistent cervical HPV 16 and 18 infections for up to 8 years, which was the maximum time of research follow-up at that point. More will be known about the total duration of protection as research continues, but at this time there is no evidence of waning immunity, such as been seen with the meningococcal conjugate vaccine, which now requires a second dose. This information will be updated as we have more data available. This is a common one too. The Tdap and meningococcal vaccines are required for school, but the HPV vaccine is not, so I'll just skip it. Although it's not required for school, one thing is clear. It is not a reflection of the effectiveness of the vaccine, but more about the nature of HPV infection. And for us, we can say, I'm recommending all 3 of these vaccines because they protect your child's health, and that is my priority. Meeting school requirements is important, but it is even more important to protect your child from cancer and other diseases. And the final question we hear from families is, well, when do we come back? The dosing schedule can be a bit complicated, but the final take-home from this is really to know how your clinic is going to handle follow-up visits, have some kind of process in place to ensure that families will be asked to schedule a follow-up, and that you revisit vaccines at the time of that follow-up. So this slide gives a list of things to think about for your clinic. Now to review what we've talked about today. Number 1, give a strong recommendation. Ask yourself, how often do you get a chance to prevent cancer? Number 2, start conversation early and focus on cancer prevention. Vaccination given well before sexual experimentation begins is best. We have better antibody response in preteens than we do in older teens and young adults. Number 3, offer a personal story. If you have your own children or grandchildren or close friends' children, relay that story. And make sure we focus on HPV-related cancer prevention. Number 4, welcome questions from parents, especially about safety. And remind parents that the HPV vaccine is safe and is not associated with increased sexual activity. Be sure to answer questions confidently and give just the answer to the question they're asking. Don't give more information than the parents have asked for. All right, so in this last section, we'll have some review questions to go through. And the first slide will have the questions, and then the next slide will have the answer. So review question number 1. HPV vaccine is recommended for the following persons. We have choices A, B, C, or D. So the answer is it's recommended for all adolescents at the 11 to 12-year-old visit. And review question number 2. What are the criteria for administering a 2-dose HPV vaccine schedule? A, the patient receives the first dose between the ages of 9 to 14. B, if the patient has received 2 doses, the doses are at least 5 months apart. C, the patient does not have certain immunocompromising conditions. Or D, all of the above are the criteria for administering a 2-dose HPV vaccine schedule. And the answer is all of the above. And review question number 3. Which of the following HPV vaccine recommendations for a child age 11 or 12 is the most likely to be successful? A, ask the parent if their child is sexually active and then discuss the importance of the HPV vaccination. B, tell the parent that their child needs 3 vaccinations today: HPV, meningococcal, and Tdap. C, tell the parent about the vaccinations that are mandatory for school entry and then ask if they also want the HPV vaccine. Or D, ask the parent if they want to get the HPV vaccination for their child or wait until their child is older. And the answer is B. Tell the parent that their child needs 3 vaccinations today: HPV, meningococcal, and Tdap. That is the end of the slides, and here are some websites for more information. The CDC is an amazing resource that I use pretty much every day, and then the Department of Health for our state also has really good information on this vaccine. I think we have about 10 minutes for question and answer or so.
Thank you so much, Dr. Evans. This is really, really helpful. Would anybody like to share a question? If you are on your computer audio, you will need to type it in the box, but if you are on the phone, you can unmute yourself and ask a question.
Hi, it was mentioned that this vaccination opportunity should be offered even at acute visits. Can you immunize at an acute visit?
Yes, you can. So definitely take the opportunity if somebody comes in for like an acute URI or a skin rash or something like that. I would definitely take the opportunity to vaccinate. Follow the usual recommendations for vaccination. If they're febrile, I would likely not vaccinate, but if they're not, then I would not miss the opportunity. The other places that I think I usually see kids is with the sports physicals and the check-ins like those where it's not a well child check, but they're coming in for something else, is a great opportunity to vaccinate as well.
This is Ala from Salmon Creek, and I'm just asking the age 9 through 10. Should we recommend, the same as we recommend vaccine HPV, the same, the message should be the same strong way as for 11 through 12?
I would say yes. It's recommended 11 or 12, but it can be given as early as 9 or 10. So if a child is coming in for their well child check, we usually talk about anticipatory things, and so I would say we've got vaccinations that are recommended coming up, including these 3. We can give the HPV now and state it that way so people can get started early. And it's a positive thing.
Thank you.
You're welcome.
And I just want to say I was not able to see presentation. It was not showing on my computer. If there is any way I could get it, PowerPoint at my email, maybe, or somehow.
Yeah, thank you. Oh, I'm sorry that it didn't work for you. That's a bummer. But we, yes, this recording is actually archived, and Karen can get you the link to that and to the slides. So yes, thank you.
Thank you.
Any other questions from the group?
It looks like somebody might be typing one.
Okay.
So we have a question in the chat box. What are the most common arguments for parents about safety concerns of the vaccine?
So I think the most common questions or things that parents bring up are around some of the myths that are spread about vaccine safety in general, and there have been a number of myths about this vaccine that are pretty extreme, that are unfounded. So whenever somebody brings up something that they've heard, usually if I'm talking with people about vaccines, I'm asking what their concerns are and asking a very open, general way to hear them out, and then reflect back. It sounds like you've heard X, Y, or Z, and then I usually respond that this vaccine is safe and effective. The Centers for Disease Control and the vaccine monitoring have not shown any of those adverse effects, and that's public information that people can actually go on the Centers for Disease Control website and see. So I usually offer to even look it up if I have time to look it up in the room. But I, again, stick with my strong recommendation and let them know that it is safe and that the most common side effects are just a sore arm or redness at the site of the injection that go away. I hope that answered that question. You're welcome.
Any additional questions?
Okay, thank you again for your time today, Dr. Evans and Sarah J. and everyone else who joined us. You can email me at the chapter if you want more information, or for those of you who are working with the Department of Health Practice Facilitator, they can give you more information too. I should have put my email up on the screen there, but you can always look at our website, wcaap.org, to find our contact information at the chapter. So thank you again, and I hope everybody has a great weekend.
Thank you, everyone.
Okay, bye-bye.